The study which we conducted to look at the long-term safety effects was very complicated to set up and to run. In this study, we recruited over 200 patients from 7 clinics across Canada who were subjects with chronic pain who were already known to be using cannabis as a medicine. Their physicians knew they were using marijuana, and they were allowed to use it during the course of 1 year. The cannabis was given to them by the study physician as much as they needed for the purposes of the study and for the purpose of their symptom relief. Over the 1 year period, they were followed up for effects on their lungs, on their heart, on the endocrine system, on their cognitive function, for side effects that were reported to the study physicians, and for a number of other parameters over the course of the 1 year period. A control group of people with chronic pain who attended the same 7 clinics who did not use cannabis was recruited at the same time, so that we could compare the effects of the cannabis to another group of pain patients. As Dr. Nutcap told you yesterday, pain itself has an effect on people's ability to think properly. It has effects, other medications may have effects on cognition. So it was important to try to control for these. And I don't have time this morning to present to you the full results. The data are still being written up for publication. But I can tell you this. The side effects that were reported during the course of the study were very similar in both the type of side effect and the intensity or severity of the side effect to normal conventional medications used in the treatment of pain. We did not see any signs that this cannabis was causing any side effects that were not expected or were of unusual severity. There were 2 deaths in the study. Both were in the control group. There were no severe side effects or serious side effects in the cannabis group that were felt to be caused by the cannabis during the 1 year. Now, I remind you that these are patients who are on average about 45 years of age. They were about 50% male, 50% female, and they had a wide range of serious chronic pain conditions like multiple sclerosis, spinal cord injury, severe forms of arthritis, and other forms of neuropathic pain. The majority of side effects that were noted were in the categories shown here: psychiatric side effects, which include things like drowsiness, feeling of low mood, nervous system disorder, which could include nausea, and respiratory disorder, cough, feeling of shortness of breath, and so on. We conducted a systematic review of the side effects of prescription cannabinoids and published it 2 years ago, and we found very similar rates and types of side effects from prescription cannabinoids. So smoked cannabis did not seem to have different forms of side effects compared to prescription cannabinoids. With respect to other prescription medications, we were very impressed by the fact that our patients were telling us that they used cannabis to help them sleep at night. And we conducted this trial to compare the effects of the synthetic cannabinoid nabilone to a standard treatment for fibromyalgia patients who have difficulty sleeping. The gold standard of this treatment at the moment is amitriptyline in very low doses, which is a tricyclic antidepressant used to help patients with fibromyalgia to sleep at night. Because this is the gold standard, and because it has side effects which are similar in some ways to the cannabinoids, causes a dry mouth, drowsiness, and some feeling of dizziness, it was an ideal comparison in a clinical trial. Patients were randomized to receive either of the 2 treatments for 2 weeks, and then they washed out for 2 weeks and were allowed to cross over and use the other medication which they had not received for the following 2 weeks. They did not know whether they were receiving the active or the controlled treatment. And you can see here that the patients, when they came in the study, had very severe insomnia. At the beginning of the study, when they were on nabilone, the effect on sleep was profound. The effect of amitriptyline was also significant, which is why we use it. When they stopped the treatment and were taken off the medications in the middle of the study, the sleep returned to being severe insomnia. And then when they crossed back over to receive the other treatment, The effects were also significant, but not as noticeable. At the end of the study, the drugs were stopped and the treatments and the sleep returned to its previous condition. When we analyzed the results, we found that the nabilone quality of sleep was better than that of amitriptyline. Nabilone was associated with more side effects, which were mostly mild to moderate, and the drug was preferred over the amitriptyline by the patients in the study. Now, with the increase in awareness in Canada of cannabinoids as a medicine, I showed you a graph earlier of the number of prescriptions being used for patients in Canada. And this has given rise to concerns from physicians as well as the patients that cannabis medicines may be used as a drug of abuse in the population. We have big problems with abuse of opioid medications like oxycodone and hydromorphone. And the drugs often come from prescriptions from doctors, which are then diverted out into the community. So the concern was that prescription cannabinoids were also being diverted and abused by people in Canada. So we reviewed a huge number of sources of data to see whether nabilone, which you can see here, the number of prescriptions has increased significantly over the past 5 years. Whether nabilone was appearing in any form on the street as a street drug, whether it was being picked up when the police did arrests of drug dealers, whether there were people in prisons who were using nabilone as a prescription medication and abusing it, whether there was any evidence that the drug had any street value. And we found very, very little evidence that nabilone has any street value. We found one website from Russia where subjects had tried to open nabilone capsules and snort the medication or to crush it and inject it, and the experience was very bad, and the web people reported that this was not a good drug to abuse in this way. So the overall rate of diversion and abuse of nabilone, we believe, is very low. However, this was looking backwards over time. We are now doing a study with 250 people who are prescribed a cannabinoid for the first time and following them over a 1-year period to see whether they develop any signs that they're having difficulty managing their medication, such as losing prescriptions, having to fill them early, using many doctors to get prescriptions. These are the kinds of behaviors that people who are using opioid medications show when they're losing control of their drug use. We will report the findings of this study in about 1 year. So now I tell you a little bit more about the medical marijuana access regulations in Canada. Health Canada, who is our Ministry of Health, allows patients access to cannabis for medical use to those suffering from grave and debilitating illnesses. It only deals with herbal cannabis access. It does not cover the use of prescription medication. These go through standard regulatory approvals. And the website is shown here. You can find this easily on the internet by just typing in Health Canada. I would remind you, if you were searching for this, that in Canada, for some reason, they spelled marijuana with an H. So remember to type it in correctly when you enter it in the website. 2 categories of patients are allowed to have cannabis with their physician's approval. Category 1 and Category 2. In Category 1, the following conditions are found. Patients with severe pain or persistent muscle spasms in association with multiple sclerosis, spinal cord injury, and spinal cord disease.